In this presentation, I will be demonstrating how to insert a large bore nasogastric tube for the purposes of decompression. I begin first by checking the doctor's order. I have an order that states insert NG tube to low intermittent wall suction. LIWS is oftentimes an abbreviation we'll see for this. And then I also have an order for KUB confirmation post-insertion. Before I go ahead and gather up my supplies, I need to consider contraindications. Contraindications to the tube, we have nasal fracture, deviated septum. This may require that I put the tube in by way of the mouth. Anticoagulation therapy. I need to take a look at their bleeding times, check the INR, check platelets, make sure that the patient's potential for bleeding is not too great. And then I also would consider any type of cranial surgery, fracture, any type of maxillofacial surgery or deformity. So anything that is going to create an alteration in the structure of the cranium whereby there may be an opening or a portal of entry that would allow the tube to go up into the brain. Also, contraindications include esophageal varices, esophageal surgery, strictures, gastric surgery, laryngectomy, and an unstable cervical spine injury. So considering all those contraindications, if none of them exist, then I am good to go. I would go ahead and gather up all the supplies that I need. The supplies are listed on your PowerPoint presentation, so you can refer to that slide for all the supplies you need. I have a 14 French nasogastric tube, Salem Sump variety, along with the insertion supplies, and I would head into the patient's room. Washing hands on the way in, I would go ahead, greet the patient, pull up the orders, and then I would check identifiers, inform the patient of the procedure. It's important to not sugarcoat the procedure being rather uncomfortable, but offer encouragement and support. Let the patient know that you're going to help him or her get through it. On the other side, when the stomach is empty, the patient should get some relief from the distension, nausea, and vomiting that they're experiencing. So with that, my patient here today, Miss Allie Adams, has given me permission to go ahead and proceed, and she has good understanding of what to expect. And so I'm going to go ahead then and get started. So I'll begin by putting her in a high Fowler's position, and then I'm going to put a chucks across the chest. And then I can place the pillow just slightly underneath the shoulders to put the head back a little bit in what you might call a sniffing position, where the nose is up just a little. Chucks across the chest. Now, in addition, knowing that this is for decompression and I need to attach it to suction, I'm going to go ahead and get my suction ready. Low intermittent wall suction is going to be at a setting that's in the green zone. We never want it higher than 80 millimeters of mercury, so 60 to 80 is probably a good place to be. So I begin by taking the lever at the top and putting it on the regular mode. I need to simulate suction by occluding the top of my tube, or alternatively kind of pinching it like so. And I'll notice where the dial goes and adjust accordingly. So getting that in the 60 to 80 range. And so just double check it, make sure it's where you want it to be. Now, if you recall, the order is low intermittent wall suction. So then I will have to flip it over to the intermittent setting, but I will set it in the regular setting because intermittent, it is going to be cycling on and off, and I don't want it to be shutting off while I'm trying to adjust the settings. All right, I'm going to change these gloves and continue my preparation here. I need to prepare some tape, one to secure the tube to the nose. So that is going to resemble a pair of pants, and I like to work with this without the gloves on. And then I need 2 that I call flags. And by flags, I am just taking about a 4-inch piece of tape, and I'm folding the ends in so we have a sticky middle but not sticky on the ends. And 1 will be used to mark the distance I will insert the tube, and the other will be used to secure the tube to the gown when I'm all done. The tape is ready, so now I can glove up again. And I need to see which nostril is more patent. So I'm going to take a look with my pen light and see if there's one side that appears to me more clear than the other. There may be debris, nasal polyps. So I'll just take a look inside to see if there's one opening that looks clearer. I could also ask the patient, occluding one nostril at a time, to take a breath in, and now the other side, big breath in. Is there one side that feels clearer than the other? And she can let me know if there's a difference, and then I'll choose the side, obviously, that feels more clear. In addition to that, I need to prep the nose with skin prep, and in the nursing lab, we don't have to open this. We'll just pretend, and we'll get the bridge of the nose so that the bridge of the nose is nice and sticky, and then when I'm ready to secure the tube, the tape will stick better. Next, I'm going to get my NG tube ready. I always want to put it in the closed position, so I'm taking the pigtail and I'm just kind of curling it around and attaching it to this adapter. And then I will measure the tube, the distance that I want to insert. So it is nose to earlobe to the xiphoid process. So I'm going to feel for the xiphoid process. And with our mannequins, we probably have to go a couple inches longer, but in the hospital setting, we never want to over-insert the tube. We want to make sure that we're careful with our measurement. The first flag, as I mentioned, is going to mark the distance I'll insert the tube, so I know I can stop when I get to the flag. I'm going to take the tip of my tube and just give it a little curve here so that it follows the nasal passage a little bit more easily. The tube has to go back and kind of hook downward. So give it just a little curl around your index finger, but don't over curl it because that could encourage it to coil in the mouth. I need to lubricate it. Obviously, in the hospital, I would be using a water-soluble lubricant. I would generously lubricate the first 4 inches. I could tear this off, put the end of the tube in the packet, and just kind of squeeze it generously on top, but about 4 inches of lubrication. Now, we begin the procedure with the head against the pillow, and I want to get the tube to the oropharynx, to the back of the throat. So patient has been instructed what to expect. So first we go to the back of the throat, we take a brief pause, make sure the tube is not coiling in the mouth, and then we ask patient to go chin to chest and start drinking some water, as long as it's not contraindicated. It's very helpful to have an assistant with you, but sometimes you do have to do this alone. And if our patient is cooperative, they can certainly help us out. So first things first, let's get it to the back of the throat. All right, getting ready to start. Going to advance the tube, never push against resistance. And we're advancing kind of in the direction of the ear here. And we'll feel that it kind of drops into place, moves a little bit more easily. And so at this point, I'm going to pause very briefly, and I'm going to take a look to see if the tube is in fact in the back of the throat. We're going to change positions. The patient would be holding their cup of water, chin down, and then I would instruct the patient to swallow, swallow, keep going, you're doing great. And I would stop when I get to my flag. At this point, I would ask the patient how she's doing, I want to hear her vocalize. That tells me that it's not passing through the vocal cords. I also am looking at her respiratory status. If she at any point becomes short of breath, starts coughing forcefully, I pull the tube back to the nasopharynx until the breathing goes back to normal. If it's really bad, I can pull it all the way out and just give her a break. But she's talking, and that's a good sign. I ask her to open wide. The tube is not coiled in the mouth. So then I would go ahead and take the flag off here and exchange it for the pants that I've prepared. So I put the solid part of this split piece of tape here on the bridge of the nose, and then I am just going to temporarily anchor this so that it doesn't come out. So just one pant leg around. Now I'm going to take my 60 milliliter piston syringe. Whenever I am opening this up, I want to kind of crimp it, kink it here, and then open it. Otherwise, it will start spilling gastric contents. Attach my piston syringe and pull back for aspirate. Now, I'm not getting any aspirate here, so in light of the circumstances, patient's not in any distress, it's very possible I have not hit the stomach, so I'm in the distal esophagus or just at the very top of the stomach. So what I could do is uncoil that pant leg I put around and then just advance another couple of inches to see if that gets the tube down into the gastric contents. All right, I advance another couple of inches, and in fact, I do get the gastric contents I'm looking for. So I have a grassy green color. I ask myself, does this look like it came from the stomach? And yes, it does. So let me just secure it again with a pant leg, because I also have to pH test it. So once again, I kind of crimp it, clamp it here with the pigtail, transfer this over to my little cup that I have ready with my pH test strip. This you read immediately, and it looks like I'm between 2 and 3. Patient then is talking, not in distress. Tube is not coiled in the mouth. Aspirate looks gastric in nature, and it's very acidic. So I can feel pretty confident that this tube is in the stomach. Of course, we need KUB confirmation. Most policies will allow you to decompress the stomach to give the patient relief even before the KUB confirmation, as long as everything is overwhelmingly pointing to the fact that the tube is in the stomach. And here we can say that it is. We cannot, however, put any fluids, medications, any feedings of any kind down the tube until we have KUB confirmation and an order that states it is okay to use the tube. So I'll complete the procedure here by securing it. Second flag goes on the tube towards the end of the tube here, close to where the pigtail is. And then I would just take a safety pin and pin it to the gown. We want the tube to remain above the level of the stomach. If it's below the level of the stomach, it tends to leak and act like a siphon. So we want it above the level of the stomach when we pin it. And be careful to lift up the gown so you don't grab anything underneath, such as a central line lumen or something along those lines. Okay, so now I am ready to attach to suction. My suction is ready. So I would just go ahead and use this tapered adapter that comes with the tube, and that is attached to my suction source. Now, as long as it's within my agency policy, I could add a blue anti-reflux valve, and if I had one, I would just put the blue to the blue, so blue to blue. Not all agencies allow for the anti-reflux valve, and some surgeons do not like them. So just make sure that you're familiar with your agency policy on that. So that concludes the insertion of the large bore nasogastric tube. Fast forward a few days, we have peristalsis that has returned. So we have, in order now to discontinue the suction, clamp the NG tube, kind of as a trial to see how the patient will do when we take the tube out. So again, I enter the room, I check the orders, I identify the patient, I let the patient know that we're going to clamp the tube. It's no longer going to be attached to the suction source. All right, so I'm gloved up. I'm just going to go ahead and disconnect the suction. I could then turn the suction off. I'm going to take the pigtail and close off the tube like so. And so now we could say the NG tube is clamped. She is no longer attached to suction. Now fast forward, let's say patient does very well and is not having any problems with the NG tube being clamped. It's time to take out the NG tube. So maybe 12 hours later, next morning, it's time to take it out. We have an order, DC NG tube. We gather up a chucks, and we have some supplies in the room. And so we would enter the room, wash our hands. We would check the order, identify the patient, let them know it's a good day. They're getting their NG tube out today. And so we're going to take our chucks pad across the chest. We have 3 things to do in order to prevent aspiration. So let me release it from the gown. And then the 3 measures to prevent aspiration of the tube, aspiration of the gastric contents that are within the tube. We're going to take 30 milliliters of air and inject it like so, pushing everything back into the stomach. Now I have to get rid of the piston syringe too, so might as well just leave it there. I'm going to take the tape off the nose. I'm going to kink or crimp the tube, kind of pinch it. I'm going to ask the patient to take a deep breath and hold it, hold it, hold it, and then pull the tube out into the chucks. Wrap it up. Put it in the biohazardous waste container. Clean up the patient, offer them mouth care, and document that we've DC'd the NG tube.